Malignant tumors of epithelial tissue origin. We know the neoplasms, they may be benign or malignant. The term malignancy is given only when the given tumor is showing the characteristic features of invasion. The epithelial cells are extrememely dysplastic, severe mitotic figures are present, characteristic features of invasion along with metastasis are very severe, and so the term malignant tumors denotes the features of metastasis in invasion characteristically. Okay, we'll see the malignant tumors which are arising from the epithelial tissue origin, and even the malignant tumors arising from the connective tissue origin. So the malignant tumors of epithelial tissue origin will be studying the basal cell carcinoma, the squamous cell carcinoma, and the verrucous carcinoma, carcinoma in situ, and even the malignant melanoma. Okay, so basically, we'll study the general characteristic features of the tumor and along with the characteristic histologic features and the oral symptoms or presentations of that particular epithelial malignant tumor. Okay, basal cell carcinoma. It's also known by other names like basal cell epithelioma or the rodent ulcer. It is the commonest of the malignant epithelial neoplasms. It is about the third common oral neoplasm, which is being seen characteristically on the skin. Sun exposed surfaces are more characteristically prone to develop this cancer, the epithelial cancer. About 90% and more, maximum of the cases are seen only in the cutaneous form, that is in the skin. The oral cavity is not involved, and the oral cavity is involved only when the tumor is invading the underlying oral squamous epithelium. From the epithelial surface, from the skin, if the tumor neoplasm is showing invasion, only then the oral cavity is involved. Okay, what is the etiology for the basal cell epithelioma or basal cell carcinoma? It is nothing but the exposure to the sun, the ultraviolet radiation of shorter wavelength, that is 280 to 320 nanometer. On prolonged exposure, it leads to development of few carcinogens in the skin, and after even a latent period of 20 to 50 years, the individual is prone to develop the cancer. Okay, the latent period is nothing but the time from the exposure to the sun and the development of skin cancer. It may be more than 20 to 50 years also. Okay, we know the most of the sun exposed skin are the middle third of the face. Okay, so the middle third of the face characteristically shows the symptoms or the clinical features of this basal cell carcinoma, and it is more commonly seen in case of females. Okay, male to female ratio is 3:2. Female predilection will be present, and males who are constantly working outdoors, they are more prone to develop. So equal predilection may also be seen, because even males who work outdoors characteristically show this basal cell carcinoma. And the feature of this basal cell carcinoma, it is a very slow growing tumor, as the latent period is also long. It is a very slow growing, but the only characteristic feature is that it tends to spread and invade the tissues, invade the underlying tissues. It just tends to spread, though the metastasis, that is the involvement of other organs, lymph nodes, is relatively later in stage. Okay, it is relatively slow, we can say. So basically the etiology is nothing but the ultraviolet radiation exposure, there is a sun ray exposure, and this disorder has been seen more commonly in white or fair skin individuals, and the darker skin individuals do not show basal cell carcinoma. Okay, you can see the characteristic appearance of the basal cell carcinoma. If we see the clinical appearances of basal cell carcinoma, it may appear in different forms, like the superficial form, the nodular form. The characteristically the seen in the clinical picture there, it's a nodular basal cell carcinoma. So we'll see what are the differences or the clinical appearances of the carcinomas, basal cell carcinoma. Okay, the nodular basal cell carcinoma, as we have seen previously, in the clinical picture, it just appears as an elevated papule like a thing, but the center of the papule will show a little bit depression. Okay, it tries to heal, there are attempts at healing, but the central portion will be just depressed. Okay, even though it is trying to heal, ulceration is occurring, and again it is breaking down the healed part. Okay, so at any given point of time, the nodule will be present along with the depression, and because ulcer formation is occurring, the tumor cells, whatever they do, they just tend to spread peripherally along the border of the nodule. So that gives the appearance of a rolled border. The tumor cells, they are just spreading laterally along the lesion, along the nodule. So that is why the term rodent ulcer or rolled ulcer is given to the basal cell carcinoma. And as I told you, the tumor cells, they just tend and infiltrate the adjacent tissue, deeper tissues. By infiltration only, the tumor cells spread to the oral cavity. Okay, they even erode the bone or the adjacent cartilage associated with it. So that's the clinical presentation of a nodular basal cell carcinoma. If we see the pigmented basal cell carcinoma, they are nothing but the nodular basal cell carcinoma with increased melanocyte deposition. So the clinically you can see that the deep brown or dark brown pigmented nodule like a thing is present. The cystic basal cell carcinoma is nothing but the clinical appearance shows a translucent blue cystic nodule. Clinically, it appears to be fluid-filled, bluish in color, and microscopically it shows cystic spaces. Okay, so the term itself indicates that. Superficial basal cell carcinoma is nothing but the appearance of basal cell carcinoma. The clinical appearance is one of the presence of erythema, scaly patches, or papules. Papules are nothing but they are not raised from the surface. They are just flat lesions about 1 mm above the surface maybe, and they may be pink or red brown in color with a central clearing, because I have told you there are attempts at healing present in the nodular basal cell carcinoma. Even though it tries to heal, a central depression will be present. So that's why central clearing is present with a peripheral pink lesion in case of the superficial basal cell carcinoma. The micronodular variant of basal cell carcinoma, it is relatively aggressive one, and the characteristic feature is that it is very, though aggressive, it is lesser prone to ulceration. That there is no attempts at healing process of this aggressive variety, micronodular variety, and clinically it appears as yellow-white, well-defined border, papillar or a nodular lesion. The morphiform or variety is a more aggressive variety with characteristic invasion, and clinically it appears as a plaques that is raised above the surface or papules, though the border is not well defined. The border of lesion is not well defined. So when you see the microscopic picture of the tumor cells basically they are the basalioma cells. The basalioma cells is nothing but the basal cells with large hyperchromatic oval nuclei and with very little cytoplasm, and these basal cells are arranged in nests or islands of cells of varying sizes in the epithelium. Okay, different islands will be seen, and when you see an individual island, the peripheral cells, they are just palisading tall columnar cells, and the increased mucin is present in the tumor cells, and because of the presence of increased mucin, sometimes cleft formation known as retraction artifact occurs between the tumor islands present in the epithelial cells and the connective tissue stroma. The stroma, that is the connective tissue, is relatively sparse. Epithelial cells predominate, the islands of epithelial cells will be more in number. Okay. And pigmented variety of this basal cell carcinoma, as the name indicates, it shows the presence of benign melanocytes in the epithelial cells, giving the characteristic formation of melanin granules, and thus leading to deep brown or dark brown color of the nodular basal cell carcinoma. The superficial basal cell carcinoma, it shows the buds of epithelioid cells, and the epithelioid cells are just attached to the underlying surface of dermis, thus giving the superficial appearance. The morphiform, as I told you, it is a very aggressive variety, so characteristic features of invasion may be present, and the carcinomas exhibit different growth patterns, resulting in the tumor cells being arranged in different nests or strands of cells. The micronodular variety, it is a relatively more aggressive variety of nodular basal cell carcinoma. The tumor cells, that is the basaloid cells, they again show a nodular aggregation of cells with the characteristic palisading of the peripheral cells, and the tumor cells being arranged in nests. And the treatment for basal cell carcinoma is nothing but because the latent period is more and the tumor is very slow growing, and the clinical symptoms are one of very invasion, and before even the clinic patients notice or diagnose the lesion may have spread and infiltrated the adjacent connective tissue, the bone, the cartilage. So it is a more of invasive and infiltrating one, though it is a very slow growing one, and though the metastasis in case of basal cell carcinoma, it appears to be very late in origin. The treatment is surgical excision of the tumor along with a border of normal epithelium so that the complete excision of basaloid cell occurs and there are no chances of recurrence. Along with surgical excision, X-ray radiation therapy is also carried out in case of basal cell carcinoma. Okay, if the normal the tumor cells are completely excised surgically, the recurrence chances are very less and very rare. So the other commonest malignant epithelial neoplasm, the most commonly seen malignant neoplasm in the oral cavity and is the squamous cell carcinoma, also known as epidermoid carcinoma. The term squamous cell carcinoma basically denotes that it's a malignant epithelium which exhibits squamous differentiation of epithelial cells, and that is nothing but characterized by deposition or formation of keratin on the surface and formation of keratin in the intercellular bridges. As with all the neoplasms, the etiology for the squamous cell carcinoma, it predominantly shows to be the usage of tobacco in any form, smokeless form, smoke form. Along with tobacco, if alcohol usage is present, they both combine to give a synergistic effect, showing the characteristic mutations in the cells, in the genes, and giving rise to the carcinoma or the dysplastic changes in the epithelium, and the beginning of malignancy starts there. Along with that, insufficient intake of vegetables, food, and also gives rise to deficiency. These deficient cells are immunocompromised or immunosuppressed, and they just tend to show rapid spread of the invasion or rapid spread of the epithelial malignancies. And vitamin A and vitamin C deficiencies also make the individual more prone for the malignant epithelial neoplasms. Okay, so the characteristic features of epithelial malignancy is the presence of induration, that is invasion of the epithelial cells is present. They are more spreading in nature, and the presence of an indurated margin. Indurated margin is one which does not show any symptoms of healing. Classification of lip and oral cavity carcinomas. We know classification applies only to carcinomas of vermilion surfaces of lips and oral cavity, all of the oral cavity including the minor salivary glands. The TNM classification is the classification used for classifying the malignancies, the spread of the malignancies, the invasion of the malignancies, at what level the epithelial malignancy has metastasized. To know that, we just to consider this TNM classification. First we'll see what are the sites which can be classified. Okay, the anatomical sites which can be classified. The lip is classified according to the ICD coding. The lip, in the lip we can we show three sites can be considered. The external upper lip, there is the vermilion border of upper lip, the vermilion border of lower lip, and the angle of mouth are the commissures. The ICD codings are correspondingly shown there. And among the oral cavity, we can classify the carcinomas in the buccal mucosa, in the mucosa of the upper and lower lips. There is the labial mucosa, the cheek mucosa, the retromolar areas, the buccoalveolar sulcus, and the lower alveolus and gingiva, and even the hard palate. And we also can classify the carcinomas seen in tongue, either the anterior 2/3 or the posterior 1/3, or the inferior or the lateral border of the tongue, and even the floor of the mouth. These were the anatomical sites. Then we'll see what regional lymph nodes are involved. Okay, to classify, we consider the site first, then the level at which the regional lymph node is involved. And how do you classify the tumor? The term T denotes the primary tumor, and if the term when writing the report or when classifying the tumor, the term Tx is given if the primary tumor is not identified. The term T0 is given if there is no evidence of any primary tumor present. The term TIS is given when the tumor shows features of carcinoma in situ. The term T1 is given when the tumor is 2 cm or less in the greatest dimension. When the term T2 denotes that tumor may be more than 2 cm but less than 4 cm. Okay. The term T3 indicates the tumor is more than 4 cm in greatest dimension. The term T4 is given when the tumor invades adjacent structures, that is the cortical bone, tongue, skin, and neck, through infiltration and through malignancy. So metastasis had occurred at a very, very advanced stage in case of T4. And now we have seen the spread of the tumor. If tumor is present or not, that is given by the term T. what regional lymph nodes are involved and how is the spread there. The term NX is given or denoted after histologic examination. You give this diagnosis in such a way that NX term is given when the regional lymph nodes are not assessed. N0 term is given when there is no regional lymph node metastasis indicating the tumor is in early stages. The term N1 is given when metastasis is present only in a single ipsilateral means same side lymph node which is 3 cm or less in maximum in diameter. The term N2, again it is of two types. It shows two types of metastasis. That is the term N2A is given when the metastasis is present in a single lymph node of ipsilateral side, same side lymph node which is more than 3 cm but not than 6 cm. The term N2B is given when metastasis is seen in 2 or 3 lymph nodes of the same side which may be more than 6 cm in diameter. The term N2C is given when metastasis is present in both the sides. Okay, unilateral, it is not as ipsilateral, it's bilateral, and the metastasis, the lymph node involvement is more than 6 cm in greatest dimension. The term N3 is given when the metastasis in a lymph node is more than 6 cm and it's involving multiple areas. If the term M denotes the distant metastasis. So in the T and M classification, the T denotes the presence or absence of tumors, N denotes if the regional lymph nodes are involved or not, M denotes the metastasis. Okay, the metastasis at what level it is present. Okay, MX, the term MX is given if there is presence of distant metastasis which cannot be assessed histopathologically. The term M0 is given if there is no distant metastasis. The term M1 denotes that distant metastasis is present. So based on these T and M classification of the tumor stage, the tumor is divided into different stages. So the tumor may be stage 1 if the tumor cells are present which are very initial in origin, which are showing carcinomatous features, and there is no nodal metastasis, and there is no nodal involvement, no metastasis. The term indicates stage 1. Stage 2 tumors, stage 1 tumors are which show that tumor, there is evidence of tumor which is more than or less than 2 cm in diameter. There is no evidence of nodal metastasis. Stage 2 tumor indicates that the tumor cells are more than 2 cm but less than 4 cm, but there is no evidence of any nodal metastasis. Then stage 3 tumor, the tumor may be 2 cm or 2 to 4 cm or more than 4 cm, and sometimes nodal metastasis may not be present. Sometimes nodal metastasis may involve single lymph nodes, and sometimes nodal metastasis may be involving ipsilateral or bilateral lymph nodes. So based on that particular areas, the staging of tumor is carried out, whatever you notice histopathologically. Okay. So these were the classification of squamous cell carcinoma or any epithelial malignancy for that matter. You have to consider this T and M classification. So we'll see the characteristic histopathologic features seen in squamous cell carcinoma, which is the commonest oral epithelial malignant neoplasms seen. Okay, the characteristic histologic features is that the epithelium, it shows squamous cell differentiation, that is deposition of keratin in the epithelial cells, and the characteristic changes appear in the cells, which are nothing but the presence of enlarged nuclei, as well as the cell size tends to increase. There are presence of a large and prominent nucleoli. Along with that, the nuclear cytoplasmic ratio is increased. When stained, the nuclei, because of large size and a large nuclei, they appear to be hyperchromatic. There is a deeply stained one, and characteristic features of dyskeratosis are seen. That is, the keratinization of cells occur with the presence of keratin even in the intercellular bridges, and mitotic figures are increased in number. So dysplastic changes begin to appear, and they are severe, and severe mitosis is seen in cases of this histologic features of squamous cell carcinoma. Okay, and based on the histologic features or the appearance of changes in the cells and the structure of the epithelium, that is the architectural structure, and the appearance of cells, that is cellular structure, based on these two criteria, the squamous cell carcinoma are graded as mild dysplasia, moderate dysplasia, and severe dysplasia. We give the term mild dysplasia or grade 1 for a squamous cell carcinoma if we see proliferation of epithelial cells in the hyperbasal and the parabasal layer. Cellular atypia is present, which is very minimal, and the pleomorphism of cells or nuclei may or may not be present, or unusual pleomorphism is present, and mitotic figures are not prominent at all. So mild dysplastic features are seen, the mitotic features are not prominent, and only the thing is the beginning of dysplasia has occurred because few of the cells show cellular pleomorphism, few of the cells show hypochromatism, and minor cytological changes, that is small nucleoli or presence of a large nucleoli or increased cell size is seen. Now we'll see the moderate dysplasia. The term moderate dysplasia or grade 2 for squamous cell carcinoma is given when the dysplastic features tend to just increase in size. Appearance of increased hyperchromatism is seen. The nuclear cells appear to be more prominent. Nuclear hyperchromatism is seen. And the presence of atypical cells begin to appear in the middle of epithelium. The rete ridges, they just become more bulbous. There is the architecture of the epithelium is just beginning to change at this level. Severe dysplasia or grade 3 is given when there is abnormal proliferation of basal layer or into the upper one third of epithelium, and marked pleomorphism of the cell is seen. Nuclear pleomorphism is more prominent, hyperchromatism is more prominent, abnormal mitotic figures are seen. The nuclei become very, very large, and multiple nucleoli may be present. The nucleoli which was initially single and large in grade 1, it has become multiple here, and there is lack of stratification, there is organization is lost because the bulbous rete structures whatever are present, they are just more disintegrated into the underlying basal cell layers, and abnormal keratinization of cells is beginning to start up. So these characteristic cytological atypical features are more severe. Mitotic activity is more prominent in case of severe dysplasia or grade 3. So these are the histologic features of the squamous cell carcinoma. So the carcinoma squamous cell, it is more commonly seen in oral cavity, and it can be occurring on any side in oral cavity, either the lips, gingiva, buccal mucosa, alveolar mucosa, palate, hard palate, soft palate, in the maxillary sinus lining, or anywhere along the vermilion border, tongue, anywhere you given site in oral cavity. Because of the presence of squamous epithelium and because of the presence of dysplastic features, it shows this squamous cell carcinoma. So histological features of any squamous cell carcinoma at any site will be the same. There is the dysplastic features will be present. We'll study the clinical presentation of this squamous cell carcinoma at various sites. Okay, the carcinoma of lip. The squamous cell carcinoma, when it is involving the carcinoma of lip, it is more commonly seen in elderly males. And more commonly in the lower lip. What happens is males are the one who work outside or outdoors for longer periods of time. The lower lip is constantly being exposed to sun. So it's more prone to develop this squamous cell carcinoma because of the etiologic factor, that is the sun exposure. And females are little bit protected from sun exposure because of the application of lipstick. So so this carcinoma of lip is relatively lesser in cases of females. And it begins on the vermilion border of the lower lip. Initially, it begins as a thickening of lip epithelium. The induration of lip epithelium is seen, and once the disease progresses and invades, ultimately ulceration of the lip occurs, and it is a little bit thickened and nodular and painful. The lip becomes painful, and once the ulceration begins to start, the crater-like defect in the epithelial grooves is seen. And more commonly it's involving the vermilion border and angle commissures. So the characteristic involvement of lips in elderly males shows this carcinoma of lip, squamous cell carcinoma clinical presentation. And the lip tumors are relatively slow to metastasize, though they just tend to invade and involve the underlying tissues. They show characteristic invasion and spread, but the metastasis is relatively at a later stages. Okay, the carcinoma of tongue, it denotes 25 to 50% of all intraoral cancers. The carcinoma of tongue, it more commonly presents as a painless or a painful ulcer, single solitary, present on the lateral border of the tongue more commonly, and it begins as a superficial indurated ulcers with very raised borders, and the dimensions of ulcer will be relatively larger in size. Initially it was thought that it was mistaken as a syphilitic ulcer, but that's not the case here. And this carcinoma of tongue, it's more commonly showing the predilection for occurrence in males, and clinical presentation of ulcer on the lateral border of tongue or the lower ventral surface of tongue will be seen. After ulcer, the ulcer just progresses to the point that exophytic mass of epithelium begins to occur, and it tends to infiltrate the deeper surface of the tooth. Because of the close relationship or the lymphatic drainage of the tongue, the ipsilateral and the contralateral lymph nodes are involved very rapidly, and this carcinoma of tongue shows metastasis at an early stage because of close relationship with the cervical lymph nodes and the submandibular and sublingual lymph nodes, and because of involvement of other salivary glands, the carcinomatous changes in that particular glands and lymph nodes are seen at a very early stage. Okay, lateral border or ventral surface are more commonly showing this carcinoma. Carcinoma of floor of the mouth. As I told you, carcinoma of floor of the mouth, it tends to arise by spread from the carcinoma of tongue because of close relationship and because of invasion of the underlying tissues. Or 15% of all cases of this carcinoma, squamous cell carcinoma, appear in the floor of the mouth. Tongue is more common. Next is this floor of the mouth, and initially it begins as an indurated ulcer which is present only on the one side of the midline. It does not spread to the other side. Initially it begins as an ulcer restricted to one side of the midline with characteristic features of induration. Once the disease progresses, it just tends to involve whole of the floor of the mouth, and even the cortex is involved by the tumor cells. It just tends to spread and involve the cortex because of early extension to the mandible, and because of involvement of this, the swelling may involve the characteristic jaw. It is very extremely painful lesion, and because of the involvement of the tongue, the carcinoma of floor of mouth or carcinoma of tongue may spread to floor of the mouth, and it leads to limitation in the mobility of tongue. It is very painful condition, extremely painful, leading to inability to speak. Dysphagia may be present sometimes, and the carcinoma of floor of the mouth, it has very close proximity to the cervical lymph nodes. Again, early metastasis occurs here. Carcinoma of buccal mucosa is more commonly the carcinomatous changes are seen in the inferior portion, that is the line is seen opposite to maxillary molars. That is nothing but the line of occlusion or the plane of occlusion. It is a constant site or source of irritation because the maxillary molars and mandibular molars, whenever they come in occlusion, they just try to come in contact with the buccal mucosa along a line. So this line, it is a constant source of irritation, and because of irritation, maybe the carcinomatous changes begin to appear there, and clinically it just presents as a painful ulcerative surface which is showing the characteristic exophytic or a papillary growth because of hyperplasia of squamous epithelium. Along with that, metastasis is also seen in case of carcinoma of buccal mucosa because the early involvement of the submaxillary lymph nodes is seen. The tumor cells just trend and spread and involve the lymph nodes, maxillary lymph nodes, and early metastasis is seen here. The clinical features are one of a ulceration. Carcinoma of gingiva is more common. Mandibular gingiva is more commonly involved. We know that gingiva is a source of chronic inflammation. There are a lot of periodontal problems occurring. A lot of irritants may be present. Initially, we see the inflammatory changes, ulcerative changes, and we may misdiagnose as them as any inflammatory periodontal conditions occurring in oral cavity. But when these inflammatory changes are present for a longer duration of time with characteristic pain and ulceration, you have to just differentiate it from and diagnose it as a squamous cell carcinoma. You have to study it histologically for any dysplastic changes present or any characteristic cells present. Okay, basically areas of ulceration occur which are very extensive, and the early involvement of mandible is also seen because of the spread of the tumor cells and infiltration to the bone. It is very frequent finding in case of gingival involvement, and metastasis because of close proximity to the cervical lymph nodes. Metastasis is very early in case of tongue, floor of the mouth, buccal mucosa, and the gingiva. The carcinoma of palate involves only about the 9% of cases of squamous cell carcinoma, and then palate, it presents as an area of ulceration which may be in the midline of hard palate more commonly, and it presents as a very painful ulcerated lesion in the beginning of midline, and because of close approximation with the bone, the tumor cells, they just tend and spread and involve the underlying bone. Sometimes the tumor cells may, because of invasion or infiltration, they may even spread and involve the nasal cavity or the nasal mucosa because the epithelial lining is proliferating because of squamous metaplasia. So early involvement of nasal mucosa is also seen. So these were the carcinomatous changes occurring in the squamous epithelial cells of all the oral cavity. We know the treatment for any epithelial neoplasm, if diagnosed early, will be the surgical excision along with the border of normal epithelium, so as to just eradicate the tumor completely, so as to reduce the chances of recurrence. Along with surgical excision, X-ray radiation therapy is also carried out, and chemotherapy is carried out to just eliminate the tumor completely, to prevent the chances of recurrence. The individual must maintain a very good nutritious diet, because of deficiency of any vitamins, or deficient consumption of foods and vegetables also aggravates the symptoms of this metastasis. Okay. So now we'll see the other commonest malignant epithelial neoplasm, that is the verrucous carcinoma. Verrucous carcinoma, it is just a Varti variant of squamous cell carcinoma. That is nothing but a squamous cell carcinoma, but different in clinical presentation than the regular squamous cell carcinoma. The histopathologic features are different in that they do not show characteristic malignancy as seen in case of squamous cell carcinoma. Okay, so we'll see what are the histologic features of verrucous carcinoma. Again, the verrucous carcinoma, the mean age at presentation is about 60 to 70 years. Etiology is same. Again, the involvement of buccal mucosa is more common. The etiology is the tobacco usage along with the alcohol usage, and significant immunosuppressive states present in the individual. So the verrucous carcinoma is more commonly seen in the buccal mucosa, gingiva, or alveolar ridge. Clinically, it presents as a exophytic or papillary growth because of hyperplasia of epithelium. Papillary growth is seen, and the surface of the lesion or ulcer, it is just covered by a white leukoplakic-like film. That is plaque-like a thing is present on the surface, which is showing ulceration. And because of hyperplasia, the squamous epithelium, whatever epithelium is involved, it shows rugae-like folds with presence of deep clefts. And when it is involving the buccal mucosa and characteristic hyperplastic epithelium with rugae-like folds is present, it tends to be very extensive and rapidly spreading lesion. This is the appearance of verrucous carcinoma in the palms, soles, and foot of the individual. If you see the characteristic margins of the tumor, they are very, very ulcerative, indurated one, and they do not show any symptoms at healing. And when it is involvement of oral cavity is seen, mandibular gingiva, the lesions spread and involve the underlying periosteum. They tend to infiltrate, and they are more aggressive in nature than the buccal mucosal lesions. Because the mandibular lesions, they just trend and spread and involve the lymph nodes relatively rapidly, and regional lymphadenitis is seen. And because of involvement of buccal mucosa, the pain, difficulty in mastication will be present, and because of involvement of bone, the extreme features of swelling and pain will be present. The characteristics of any squamous cell carcinoma or a squamous cell carcinoma variant are nothing but ulceration and induration of the margins, presence of ulceration and induration of the margins. As I told you, the histologic features are different. The epithelium, it shows characteristic hyperplasia, and there is deposition of parakeratin in the epithelium that is leading to formation of parakeratin plugging. This parakeratin or keratin deposition seems to extend into the underlying connective tissue from the epithelial surface. So that is the appearance of this. Presence of prominent rete ridges or rete will be present, and the keratin, whichever is deposited on the surface, seems to just accumulate into the underlying rete ridges. So epithelial proliferation is marked without features of true invasion. That is, the epithelial islands itself are not seen in the connective tissue or the rete ridges. Just the keratin deposition is seen. Mitotic activity is relatively less in number, because the dysplastic features are not so prominent to be diagnosed as this squamous cell carcinoma. Only feature is the keratin deposition is seen, but the characteristic dysplastic feature, if we see a dysplastic cell, there will be increase in size, there will be increase in nucleus, there will be increase in nuclear cytoplasmic ratio, characteristic appearance of intercellular bridges, that is keratin, will be seen if we see the dysplastic cell. But all those features are not present here. Nuclear hyperchromatism, nuclear cellular pleomorphism, all those are dysplastic features which are not so prominent in case of verrucous carcinoma. The presence of parakeratin along with parakeratin plugging is more characteristic feature here. Epithelial proliferation is seen. The rugae-like folds are present. Treatment again for this Verrucous carcinoma includes the surgical excision along with radiation therapy if required. Okay, chemotherapy, the patient has put on chemotherapy to ensure complete remission of the tumor. Now we'll see the other commonest malignant epithelial neoplasm. There is a malignant melanoma. Melanoma basically it is a tumor, epithelial tumor occurring on the skin, as we are more commonly aware of melanoma occurring on the skin. It is the third most common neoplasm occurring, malignant neoplasm occurring. It is relatively rare in oral cavity. Oral melanomas are rare but encountered. So what is the etiology of melanoma? A melanoma, as the name indicates, it is nothing but the proliferation of epidermal melanocytes. Okay, the etiology is again the exposure to sun or exposure to any other etiologic factor, the genetic factor, the physical features. That is again the melanoma is more commonly seen in fair-skinned individuals who are exposed to sun for longer periods or longer duration. And artificial ultraviolet radiation exposure also leads to melanoma. Other common etiologic factors which are responsible for epithelial neoplasms or dysplastic features arising in cells are the genetic mutations or the predominant features of smoking, alcohol intake, poor oral hygiene, irritation from the teeth, dentures or other usual appliances. So the epidermal melanocytes, they are showing the dysplastic features, that is the characteristic proliferation of epidermal melanocytes, and metastasis and invasion is occurring from the epidermis into the underlying connective tissue, and they lead to rapidly spreading malignant neoplasms. So we'll see what are the characteristic features of malignant melanoma. It's basically clinical features are presenting in different forms. More commonly, melanomas are seen about third or fourth decade of lives, and I think females are more commonly predicted because of their characteristic fair skin and exposure to sun. So the different clinical forms of malignant melanoma includes the superficial spreading melanoma, that is seen in about 65% cases of malignant melanomas. Here it is the clinical appearance is one of pale, flat, tan macules which are black, brown or admixed in nature and characteristically seen on sun exposed surfaces. Okay, the clinical picture of superficial spreading melanoma. Then the nodular melanoma, as the name indicates, the clinical presentation is one of appearance of nodules which are raised from the skin surface. About 13% cases of malignant melanoma show nodular appearance, and these nodules, they are sharply delineated from the surrounding mucosa, and sometimes they appear to be dark brown or deep brown color because of increased pigmentation. Lentigo melanoma, that is nothing but the appearance of freckles. Freckles are nothing but discoloration seen on the skin surfaces which tends to be diffuse in nature, which are pigmented, which appear to be darker in color compared to the surrounding skin. So the appearance of freckles is common in case of lentigo melanoma, and about 10% cases of malignant melanoma show this appearance. It was previously known as a melanotic freckle of Hutchinson. Okay, the lesion is nothing but a macular lesion which tends to be diffuse. Acral lentiginous melanoma. Acral lentiginous melanoma is a relatively extremely severe form of melanoma because the initially it begins as a macular lesion with increased pigmentation around surrounding a nodule. So centrally a nodule is present, surrounding that a macular lesion is present, so it tends to be relatively diffuse in form. So here you can see the characteristic differences in the clinical picture. You can see the difference between a mole and a melanoma. Okay, the mole sometimes it may have the hairs extruding from the surface. The melanoma doesn't has that features. It is just for about a few to centimeter in size, and it shows that deep darkish brown color, and it is just fixed to the underlying periosteum or the underlying skin or connective tissue. It is not that freely mobile. Mucosal lentiginous melanoma, as the name indicates, occurrence of melanoma or the discoloration or nodular lesions is seen in the mucosal surfaces of the oral cavity, pharynx, gastrointestinal tract, esophagus, anywhere, even the pharyngeal pillars, facial pillars, the mucosal linings of epithelium, anyway you can see the appearance of this melanoma. Okay, even the respiratory, gastrointestinal and genitourinary system, so we can be detected on endoscopy. Amelanotic melanoma is nothing but appearance of erythematous or pink color nodule which sometimes shows erosion. It is more severe in form. And how do you diagnose the case of melanoma? How do you differentiate it from a mole? Is for the diagnosis, for any lesion to be given the diagnosis of a malignant melanoma, the clinical appearance should be one which should be taken into consideration, and it should show the characteristic features as follow. It should show a asymmetry, that is, one half of the border should not match the other half. So if you see a melanoma, a melanotic macule or a nodule, it should be like spreading one. It should not have any correlation on the if you divide the nodule into two halves. And if you should see the border should not be well circumscribed. Okay, the border should be irregular, or it should be blurred, notched. It should have ragged edges. And if you see the color is also not uniform. At few sides it should be dark brown, at few it should be appearing light brown in color. So pink or erythematous mixed lesions may be seen. And when you measure the diameter of the lesion should be greater than 6 mm to be diagnosed as a melanoma. And if you see the appearance of the lesion, it should be slightly raised from the surface. So asymmetry, border, color, diameter, elevation. That is nothing but the A, B, C, D, E rule for diagnosing the malignant melanoma. So as I told you, oral melanomas are relatively uncommon in origin, or they may arise in places of congenital nevus present in the oral cavity. That region, if it shows dysplastic features, it may develop into a melanoma. If it is occurring, if the oral melanomas are occurring, they are more common in case of male, seen more commonly on the hard palate, that is, or the maxillary gingiva. It appears as just as a deeply pigmented area, sometimes with areas of ulceration which may be raised above the surface. And as the age advances, the melanomas tend to increase in size with increasing age. So that was the clinical picture of a malignant melanoma. When you see the histologic picture, as I told you, malignant neoplasm of epidermal melanocytes. So epidermal melanocytes show the characteristic clinical features here. So how the malignant cells appear? They appear either in nests of cells or groups or cords of cells. Okay. The melanoma cells, if you see the individual cells of melanocytes, they appear to be relatively larger in size, with a large nuclei, prominent nucleoli may be present, and pseudo inclusion, that is presence of any foreign body that is nothing but the melanin granules or any foreign body may be enclosed within the cytoplasm of a large melanoma cells. And the distribution of melanocytes varies in all different forms. For the nodular forms of melanoma, the melanocytes are basically, they are concentrated only in the epithelium. They do not extend into the connective tissue. And for the superficial spreading type, large epithelioid melanocytes may be seen in a pagetoid manner. That is nothing but they tend to spread laterally or in a diffuse manner. For sometimes again they appear to be relatively static at few levels. Okay, as one proceeds from epidermis to the underlying connective tissue. Okay, that is nothing but at few areas widely scattered melanocytes will be seen. At few areas they may not be prominent. So giving the term, this form of spreading is also known as the buckshot scatter of the epidermal melanocytes. As I told you, nodular melanoma, it shows the presence of epithelioid melanocytes which are confined to the epidermis initially, then they tend to spread and involve the connective tissue. In the lentigo maligna, it is basically a characteristic macular lesion clinically. The melanocyte is relatively atypical in that it does not show any inclusions. Okay, the nucleoli also may be prominent, and along with that, the epithelium shows the characteristic invasive features of the melanocytes. Okay, few of the spindle-shaped cells may be seen in case of lentigo maligna, that is the freckle. Treatment for any form of melanoma includes surgical excision after histological identification and chemotherapy. And whenever you are excising the lesion, you have to just make sure that you are removing a border of the lesion, because the malignant melanoma cells are infiltrative one. Dysplastic features may be present in the surrounding edges in normal cells. So about 1 centimeter border of the normal epithelial border is also removed. Okay, chemotherapy, immunotherapy, and radiation therapy further help us in keeping the invasive spread under control after surgical excision. So these were all the malignant epithelial neoplasms.